We're talking about rheumatoid and osteoarthritis. I won't elaborate into the epidemiology, not much into the pathogenesis as well, but safe to say that there's a basic common pathway, that is activation of macrophages, the inflammatory process, the release of cytokines, in particular TNF alpha and interleukin. So that is common to both rheumatoid arthritis and osteoarthritis as the end part of the pathway. So that's depicted by way of pictorial representation, but what this slide really says basically is that macrophage gets activated, and once that macrophage gets activated, we have release of these cytokines, and then the inflammatory process starts. What does this inflammatory process do? It simply damages everything musculoskeletally. So synovium, it damages and causes a pannus, as we very well know as orthopods, and then that slowly increases to damage the articular cartilage and far-reaching consequences on the joint. But what we are here for today is something that was touched upon in the last talk, the nuclear factor kappa B. This is a transcription factor in this whole process, and this, if switched on, causes inflammation as such. This causes a release of that inflammatory process. We did see in previous slides, and we'll repeat those slides here as well. So what we focus on is the NFKB pathway, as was alluded to in the previous talk. If this is switched on, then the inflammatory process starts, and therefore you have various consequences of that inflammatory process, as I said. So the master switch of inflammation. How does that happen? Inflammatory stimuli, they cause IKB kinase, that's an activator, to dissociate the inhibitor to NFKB. NFKB then enters into the cell, activates the genes which release inflammatory mediators, and the cell then releases these mediators, and those mediators, as I said, basically cause the common pathway to rheumatoid and osteoarthritis in causing damage to these structures, the synovial membrane, the chondrocytes, and bone. So, why is that significant? Where can we stop this whole process from happening? And what we have today with us is not something that is stopping this whole process from happening, but simply palliative, or treating the symptoms as such. So NSAIDs and steroids simply treat the symptoms. They do not intervene in the pathway at any stage. DMARDs, basically, they do come into the pathway, or rather interfering in the pathway at certain stages, but they have long-term side effects. Basically, there is a therapeutic dose within which they should be used, and in a practical scenario, you have these patients switching on and off symptoms pretty much often, and therefore there was the introduction of biologics, basically. But again, biologics basically they intervene at the cytokine stage, and they're cytokine specific, so it'd be interleukin specific or TNF alpha specific as such. And so we need something that could inhibit the release of all these cytokines altogether. That's where the innovation is, and as was said at the very start, the younger Mr. Modi basically believes in innovation, and can you believe it, haldi can probably, or an extract from haldi can provide a molecule that inhibits the release of cytokines, that inhibits the formation, or inhibits, yes, the formation of cytokines altogether. So this molecule holds promise. Preliminary studies, so on a grassroots level, on a practical scenario, it still needs to be seen, but this holds promise in that it controls this master switch of inflammation. So it controls the NFKB inhibitor, and if the NFKB pathway is not stimulated, you will not have these inflammatory mediators released. So how does it do that? We had this exact slide in the previous lecture. It does inhibit the activator which dissociates the inhibitor to the NF-kB molecule or the NF-kB particle. And therefore, the NF-kB particle remains inactive. That's the first step where it can sort of interfere. And then it prevents the NF-kB from entering the cell. So translocation of the nucleus it prevents, and also prevents the release of these cytokines. So again, as I said, broadly, this molecule holds promise in preventing the release of cytokines altogether, which are, as I said, pathogenic in both osteoarthritis and rheumatoid arthritis. What is the evidence? To be honest, there's a lot of evidence that you will see out here, but this is preliminary. And this certainly does not match level 1 evidence as such, basically. But as I said, basically in practical scenarios with times to come, with numbers to treat, we would see stronger evidence either coming for or against. But yes, again, broadly speaking, it's effective and safe in patients with active rheumatoid arthritis. It is well tolerated. It is well tolerated with newer technologies, because with when newer technologies were not present to manipulate this molecule, then there were a lot of gastrointestinal side effects, nausea, vomiting, and diarrhea. But with newer technologies, this molecule has been sort of cut down in size, and so its bioavailability has increased. It relieves pain and reduces the need of NSAIDs and steroids. So basically, if used synergistically, basically, it would reduce the needs of the prevailing drugs that we do use for symptom relief. If used alone as well, it has, in comparative trials, a better effect than diclofenac, so a better effect than NSAIDs as well. So it's as effective, and it has lesser side effects. There is, as I said, basically a role of it as a monotherapy molecule as well, and when combined, a synergistic effect. Now, the conventional molecule, as I said, basically did not have good bioavailability, and it wasn't very well tolerated as far as the gastrointestinal system was concerned. But that is the new technology, as I said, the SMEDS technology, basically, which drops the size of the molecule, and therefore the target tissues have better bioavailability. And this certainly holds promise, and these are just studies to show the same effect. So, in summary, curcumin basically holds promise for the future. It still needs to be seen with more detailed studies, with more levels of evidence, better levels of evidence as to whether it really does the job or not. Newer technologies certainly increase the bioavailability, so we do have the desired dose in target tissues, and we just need to wait and watch for times to come. Thank you.